We're really happy to have a special guest with us today as part of our Ceribell webinar series. Dr. John Rickelman Jr. He is a critical care physician and intensivist in the Western Illinois area, and previously the ICU Medical Director at Blessing Hospital. What really makes him a powerful speaker, though, guys, is that he has over 17 years of critical care experience and working with a variety of patient populations. And that includes altered mental status patients and sepsis patients, which is the topic of discussion today, and really how these patients can be at high risk for non-convulsive seizures.
Thank you for taking the time to actually come listen. So we're here to talk about the acutely altered septic patient. Everybody has seen this person at some time or another. I don't know where you are in your careers, but we've all seen that confused patient, the confused grandma that comes from the nursing home that always gets a little bit disoriented when she has a urinary tract infection. And I entitled this, Did You Know This? Because I didn't, because in my 17 years of experience, I just sort of thought it was par for the course. You know, you saw that septic patient, you knew they were confused, and that was just what happened. And as you treated them, they got better. Sometimes they didn't come all the way back, sometimes they did. But you knew that really all you could do was treat the underlying problem. And as I've gone through my career and as I've begun working with Ceribell and expanded my job with Ceribell, you know, there's more to it. And that's what we're going to talk about today. So what is the altered patient? Well, you know, when we talk about organ dysfunction in septic patients, this is the neurologic manifestation. So, you know, ARDS is the pulmonary manifestation, AKI is the kidney manifestation. Well, that altered patient is the neurologic manifestation. And in the past, and I know I speak for myself predominantly, again, I just thought it was par for the course. I just thought that's what happened. And what happens is that there's neuroinflammatory processes. The blood-brain barrier is damaged. I always thought that was only a big issue when it came to meningitis or direct CNS infections, but all septic patients can suffer some measure of blood-brain barrier derangement. Vasogenic edema can also be noted on imaging. Keep that in mind because we'll talk about that a little bit later, but that's actual swelling of the white matter of the brain. Cells that are called microglial cells will get activated, driving this dysfunction. There's neurotoxicity, excitotoxicity, hyperactivation. That's what causes the subsequent brain dysfunction that can occur in the presentation of how that patient will look at you. They can also be ischemic mechanisms due to impaired autoregulation. While we all talk about that target of an MAP of 65, in some cases that may not be enough. And so because sepsis and the inflammation affects the blood flow, it causes that. And it causes the brain's susceptibility to changes in blood pressure far more than the average person. And then finally, there's mitochondrial dysfunction. So for those that don't remember basic science, the mitochondria are the energy powerhouses of the cell. And so if these things are altered, their ability to use oxygen is compromised, then obviously brain tissue is going to be compromised. And that leads to that patient seeming more confused, a little bit more disoriented, and subsequent injury that can occur from it. So why do we care? Well, sepsis is a lot. There's a lot of sepsis. I mean, you're talking 1 million patients. I mean, I don't know about you, but I see a septic patient probably every single day. I may see multiple septic patients every single day. In a 2-decade study in the US, hospitalizations identified an increase in the incidence of sepsis among hospitalized patients by 8.7% per year. And it accounts for 50% of hospital deaths. So we're not talking a small number of people. We're talking, this is something that every hospital sees across the country. When, depending upon the definition that you're using these days, and the Step 1 definition of sepsis, severe sepsis, and septic shock, you can see rising courses of mortality. So 10 to 20% for sepsis, up to 80% for septic shock. It's the #1 cause of hospitalization in the US. It accounts for acute sepsis hospitalizations, and skilled nursing are estimated to be upwards of $62 billion. I don't really care necessarily about the money over my practice, but when you look at the impact on the nation and we look at the return on investment, when you start trying to contemplate and categorize how this impacts our society, it's both financial as well as personal. The studies investigating survival and sepsis deaths report slightly different numbers, but it appears on average, 30% of patients diagnosed with severe sepsis do not survive. Up to 50% will then suffer post-sepsis syndrome. So while they may survive their hospitalization, they're affected long-term. So why do I have the M star? It's because during Sepsis Alliance Month, or Sepsis Alliance and Sepsis Awareness Month, which is the month of September, you know, the mental decline of the patient is a key feature. It may be one of the first features. That grandma, that grandpa that has a urinary tract infection may just be a little less focused, a little more confused, maybe even very sleepy to the point of almost coma. And that may be their initial presentation. Because they're on beta blockers, they may not be tachycardic. Because they take Tylenol, they may not have much of a temperature. But they'll present extremely ill and have mental decline. Why else do we care? Well, looking at GCS, 15 being normal, even just a slight decrease in their mental status is important. And it does have prognostic outcomes. So that alteration of their awareness is not just par for the course. It is predictive of their long-term outcome, and it can be predictive of their mortality. Inpatient hospital admissions with the mildest severity of sepsis was associated with a 3-year mortality above 50%. So again, they made it to the hospital. They made it through their treatment. But now that 3 years, greater than 50% of those people are dead. In the patients that had septic shock, it exceeds 75%. So while we may still save these patients acutely, something is affecting them. Something long-term is affecting them and leading to poor outcomes. So while they do survive the hospitalization, they may not make it 5 years. They actually have an increased risk of suicide within 2 years after recovery. Now that may seem odd, but you're directly affecting the brain, how that person then perceives the world. Depression, PTSD, even a dementia-like state can occur. You can see suicide. It makes sense that might actually happen. 51% of the septic patients will not have returned to work within 1 year. So this is a very, very large impact that it spans not just the hospital stay, but that person's long-term morbidity and survival. 52% of all septic patients, the cerebral imaging is unremarkable. Well, that altered state, we always look at the CT scan. We want to make sure there's not a bleed, something that's acute that we need to deal with. But many times, half of them, there's nothing. In a prospective observational study, when they looked at MRI, they actually found ischemic lesions, though. Remember, we talked about, or I mentioned earlier, that there's alterations in the blood flow. And so those patients could actually show stroke-like findings on MRI. Maybe not to the fullest extent, but at least that alteration in blood flow is affecting them at the ischemic level. EEGs, which obviously is one of the reasons why we're here to talk about, given what Ceribell does, but EEGs have been seen as far back as 1992, which is quite a few years ago for some of us, that it was showing some certain pattern. The grade 4 suppression is actually predictive of mortality. So while that patient may be interactive or barely interactive, that change in their brain, not chemistry, but their brain electricity can be predictive of of poor outcomes long term, irrespective of the treatment that they are able to accomplish. Highly predictive mortality, as I mentioned, with suppression, upwards of 70% of those patients are going to die. If they're confused at the time of the EEG, if they are showing active confusion, 32% are actually having electrographic seizures in a patient that otherwise had no other medications. So that patient presenting to the hospital, that grandmother who's presenting a little bit lethargic, a little bit less interactive, seizures may be the primary cause. And that's, again, one of the reasons why we're here to talk about it. So as I expanded my role with Ceribell, and as I've been engaged with using point-of-care EEG, I started looking at these patients that I take care of, and I realized that altered mental status, it means more. It means a lot more than probably we're letting on. We all look for CT scans and MRIs looking for a bleed. We all look for hypercapnia, and we all look for hypoglycemia. But non-convulsive status is a player. In the septic population, it can be upwards of 32%, as I mentioned in the previous slide, are actually having seizures. And why is this important? Because it's something you can do something about. Obviously, if you check them and it's negative, sometimes all you can do is treat the sepsis and then hope for the best. But if there is something like a seizure that's in front of you, you can do something about that. That's why it's imperative to look as quickly as possible. In the ICU, seizures do predominate. There's a significant number across a wide swath of different diseases. And in the case of sepsis, as I mentioned, 32%, vast majority of those are non-convulsive. So that patient's not going to be sitting there actively convulsing, contracting, or showing you that there's something going on. They may simply be that lethargic grandmother who rolls in the door. So what can you do about it? Well, we mentioned vasogenic edema earlier. And vasogenic edema is basically the swelling of the cells. They've been injured for whatever reason, in this case, septic cause, and they swell. I put this small study in here because I've used hypertonic saline over the years to try to resuscitate my patients, trying to minimize total amount of volume that we give them. And what intrigued me about this study was, number one, they used hypertonic solution, but the other was they looked at GCS. And you can see in the patients that were treated, which is the red line, there's actually an improvement by day 3 or 4 of their GCS status. Now, the study wasn't for that reason, but if vasogenic edema is a potential cause of that person's confusion, maybe that treatment may be beneficial. I mentioned earlier alterations in blood flow to the brain. Over the course of my career, I've used norepinephrine, and when we first started in training, norepinephrine used to be called leave them dead instead of leave them fed, because it was believed if you're using that drug, that person had no chance. It subsequently changed to become the first-line agent for septic shock. And interestingly, in pre-hospital administration of norepinephrine, they actually showed a 30-day an improvement in mortality at 30 days. So not only did you save them to the hospital, but they actually did better 28 to 30 days out. So the early administration potentially affecting that cerebral blood flow may have been beneficial. As I mentioned, that autoregulation, while we target an MAP of 65, maybe that's not enough. Maybe in some patients, 70 is going to be the case. The average septic patient is 65 years of age or older. Large number of Americans are hypertensive, and they may live in a higher arterial pressure than just the 65 range. While we target that as a population, the individual is challenging. And so how to do that is obviously going to be a challenge that we have to face. Why is it important to find the seizure? So if we decrease the edema and we control the blood pressure, that patient still could be seizing. And the imperativeness of determining that that's not the cause for their ultimate mental state is shown in this slide. And while this is an older slide from 1993, there are subsequent trials that confirm this. The earlier treatment, the better. And when we say earlier, 30 minutes. So how long has that patient been in that state? They roll into the ER, they've been sick for a couple of days. The longer we wait, the worse the chances of changing that outcome there is. In this case, if within 30 minutes you can treat that patient, you have an 80% chance of actually affecting them with one drug. But what does that mean? That means you have to also look. It means you have to do an EEG. If they're non-convulsive, we're not going to know. You have to figure out a way to figure out that answer, and that's where the EEG comes in. If you wait greater than 2 hours, you drop off in effectiveness to 40%. What does that mean? That means you may be talking about 3 or 4 medications. The more medications you add, the longer the less their chance of getting out of the ICU in a short period of time. The more likelihood they're going to worsen to the point of needing intubation. You can only imagine what that may lead to. Ceribell did a study called the DECIDE trial, and what was intriguing in this one was, number one, we can show the speed of administration of the ability to look at that brain and see what the EEG does. Even in large centers like Rush, which is in my state of Illinois, it still took them 4 hours to get EEGs done. Why? Because there's not a lot of devices and there's not a lot of techs. The beauty of having a point of care device is that you can get it on that person's head the moment you think it's necessary. What else was important was the clinical judgment, though. I found this more intriguing because we treat empirically all the time. We always make a clinical decision based on the information in front of us. And if that information is lacking, we make decisions sometimes that don't go the way we want it to. And the more information you can have, the better. And so in this case, they showed clinical judgment improved, their confidence in clinical judgment improved 86% from 40%. Back still along the lines of duration, the longer that they are left in that state, the worse their outcome overall. So when you wonder about why septic patients may have a high mortality, well, maybe it's not the shock. Maybe it's the fact that the brain has been seizing from the moment they came in the hospital, and no one knew to look. And so you can see if you treat them within less than 10 hours, morbidity, which is their neurocognitive stat, is around 30%. But the mortality is less than 10%. If you get out to 20 hours, let's say they make it a full day without any kind of treatment, unrecognized seizing, 85% mortality. Underscoring the need for rapid diagnosis. When I first was approached for working with Ceribell, this is one of the first studies I found, because one of the things I know I see a lot of septic patients, and I'm sure a lot of you probably do too. And so when I plugged in sepsis and EEG into Google, which, just to search what was out there, this was one of the first ones that came out. I want to point out a couple things. Number one, this was 2005 to 2013. Not to date myself completely, but I just got out of fellowship in 2005. So this is older information because we were resuscitating patients a little bit differently back then. But what was intriguing is against the general population, matched for age, matched for severity, if that patient had been septic in the hospital, they had a 5 times increase the risk of developing long-term seizures. I point this out, and one of the reasons why my title is what it is too is none of this is talked about in the guidelines. If you get a chance to read the resuscitation guidelines for sepsis, there's no mention. There's no mention of seizures. There's no mention of this long-term morbidity. There's no target. There's no suggestion. It's just not there. We talk about ARDS and pulmonary manifestations. They talk about AKI and kidney manifestations, but this is nowhere to be seen. And this is one of those things that I think is important to recognize is there and start looking for it. Further impact of sepsis. So this was from 2020 data. This is worth investigating if you manage this population. But for the patients that are inpatient, here's some astronomical numbers. Only 57% make it home. That's quite a large population that doesn't make it home. You're talking 32% of the patients are dead if they, from the hospital itself. But there's also a large population. Almost 8% of them will either go to nursing home or skilled nursing facility. So you have people that went into the hospital potentially fairly functional, and they're going home either not making it home, I should say, they're passing away, or they're extremely debilitated. And you got to, as we look at these diseases, realizing that what we do in the hospital has a long-term ramifications is imperative. And lack of recognition as well as recognition are both important things. As opposed to a non-septic patient, almost 80% of those people make it home, 13% mortality, and you're talking about 5% go to the nursing homes or skilled nursing facilities. If they make it to the skilled nursing facility, almost a similar fashion, about closing in on 50% will make it home. Rest, a large portion, 15% will stay in nursing homes. About 2% will go back to the hospital, but there will be a significant mortality. If they go back to the hospital, you can see, and that's opposed to a non-septic population. So sepsis in of itself is its own risk factor for these patients. And so finally, as you try to wrap your head around what does this mean for you? How are you supposed to look at your patients? I can tell you over the past couple of months, as I've done more research and more investigating and just looking what's there, I've changed how I do things. And I can't say that every septic patient gets evaluated. It's very patient specific. I've had patients come to me from outside institutions with worsening mental status, and I'm very quick to look for seizures. I can't say it's in every single patient. We're still talking only 30%, which is a decent sized number, but there's 70% that aren't. But I got to look, just like doing a CT scan for a bleed, I got to look and make sure there's not something like a seizure that I need to treat. And so EEG, in my mind, is at the top of the list. When you look at the sort of hierarchy of bad, when you start from the first change in condition, what you're looking for with these kinds of measures, EEG is right up there. Because untreated, as I think I pointed out, the long-term outcome for an untreated seizure is abysmal, and you're not giving that patient the best chance possible. But after that, don't forget there are other things. And just because they may have presented with sepsis, that doesn't mean they didn't stroke. I know when COVID was ongoing and I had these patients that wouldn't necessarily wake up after we decreased sedation, I went straight to CT scan and sometimes straight to MRI because there was a large portion of them that had strokes. Post-cardiac arrest victims, it's a unique population, obviously, but you got to look at your medications. Those can cause their confusion, whether they were hypoxic, whether they have liver involvement, maybe they're uremic from kidney injury. Just because they're septic doesn't mean there isn't something else going on, and you have to chase those things down and treat what you can. So that's a quick run through. This is one of my favorite sayings. My job here, as I see it, is not necessarily to teach you something as much as it's just to start making you think. Because I can tell you over the past few months, my practice has evolved and has changed. And I think, if nothing else, recognizing that there is this thing out there that you need to look for, it could be the difference between changing the outcomes of that patient and not. Thank you, guys. Take care.